Here's what we'll cover in this video. Every year, millions of patients start a statin to protect their heart, and a meaningful fraction of them quietly stop taking it because of muscle pain nobody could fully explain. In July 2026, researchers finally cracked open the molecular black box behind statin-associated muscle symptoms, and the answer surprised even the immunologists. Statin-associated muscle symptoms, abbreviated SAMs, affect an estimated 7 to 29% of patients on statin therapy, depending on the population studied and how symptoms are defined. Given that statins are prescribed to hundreds of millions of people worldwide, even the low end of that range represents an enormous clinical burden and a major driver of medication non-adherence. Symptoms classically involve the large proximal muscle groups, the thighs, hips, shoulders, and upper arms, presenting as symmetric aching, stiffness, or weakness that typically emerges within the first few months of starting therapy or after a dose increase. This distribution pattern is itself a diagnostic clue that helps distinguish statin myopathy from other causes of muscle pain. Consider a 58-year-old woman started on high-intensity atorvastatin after a myocardial infarction. 6 weeks later, she reports bilateral thigh and shoulder aching, worse with exercise, with normal strength on examination and a creatine kinase only mildly elevated. This is the textbook presentation clinicians have struggled to explain mechanistically until now. Among patients who discontinue statin therapy, muscle-related complaints account for the majority of cases, far outweighing liver concerns, gastrointestinal upset, or other reported side effects combined. This single symptom cluster is arguably the biggest obstacle to long-term cardiovascular risk reduction at the population level. High-yield exam pearl for the spectrum of statin muscle toxicity. Think MR. Myalgia is pain without a CK rise. Myopathy adds a CK elevation, and rhabdomyolysis is severe muscle breakdown with CK typically above 10 times the upper limit of normal, myoglobinuria, and risk of acute kidney injury. To understand why statins hurt muscles, you first have to understand why they work at all. The story starts not with cholesterol itself, but with a single rate-limiting enzyme buried in the endoplasmic reticulum of your liver cells. That enzyme is HMG-CoA reductase, which converts HMG-CoA into mevalonate, the committed, rate-limiting step of the entire cholesterol biosynthesis pathway. Statins are structural analogs of HMG-CoA that competitively occupy the enzyme's active site with roughly 1,000-fold higher affinity than a natural substrate, shutting the pathway down at its very first checkpoint. Downstream of mevalonate, the pathway branches to produce not only cholesterol, but also isoprenoid intermediates, farnesyl pyrophosphate and geranyldryl pyrophosphate. These isoprenoids are essential for a process called protein prenylation, the lipid anchoring of small GT polysaccarides like Rho, RAC, and RAB to cell membranes. This branch point is the key to the entire muscle pain story. Pharmacologically, statins act as competitive, reversible inhibitors of HMG-CoA reductase. Reduced hepatic cholesterol synthesis triggers SHRB2, mediated upregulation of LDL receptors, increasing hepatic clearance of circulating LDL cholesterol from the bloodstream. The mechanism responsible for the roughly 25 to 50% LDL reduction seen with high-intensity statin therapy. The cardiovascular benefit of this mechanism is not in question. It is among the most robustly proven interventions in medicine. The landmark 4S trial showed roughly a 30% reduction in coronary mortality with simvastatin, and Jupiter extended this benefit to patients with normal LDL but elevated inflammatory markers, reinforcing that statins save lives well beyond cholesterol numbers alone. High-yield history pearl. Akira Endo, first isolated compactin, the prototype statin from Penicillium fungus in 1976. Levastatin became the first FDA-approved statin in 1987, and by the mid-1990s, trials like 4S had transformed statins from a promising idea into the cornerstone of cardiovascular prevention we know today. For decades, The leading theories to explain statin muscle pain were incomplete. Mitochondrial dysfunction from reduced coenzyme Q10 synthesis, direct effects on calcium handling channels, and even a purely psychological nocebo effect were all proposed, but none fully explained the biology and none pointed toward targeted treatment. Before blaming the statin, clinicians must work through a differential. Hypothyroidism, polymyalgia rheumatica, vitamin D deficiency, primary muscle disease, and simple exercise-related soreness can all mimic statin myopathy, and up to half of patients who stop a statin for muscle pain turn out to have symptoms unrelated to the drug when re-challenged under blinded conditions. Clinically, statin-associated muscle symptoms are graded by severity. Myalgia involves pain or weakness without a significant creatine kinase rise. Myopathy adds a CK elevation, typically up to 10 times the upper limit of normal. Rhabdomyolysis, the most severe grade, features CK above 10 times normal alongside myoglobinuria and acute kidney injury risk. Risk of muscle symptoms is dose and potency dependent. High-intensity statins like atorvastatin in 80 mg or rosuvastatin in 40 mg carry higher risk than low-intensity regimens, and risk rises further with drug interactions that inhibit statin metabolism, particularly CYP3A4 inhibitors like clarithromycin, itraconazole, or grapefruit juice in the case of simvastatin and levastatin. Back to our 58-year-old patient. Her creatine kinase returns at 280 units per liter against a reference range of 22 to 198, mildly elevated, consistent with statin myopathy rather than rhabdomyolysis. This pattern, mild CK elevation with preserved strength, is exactly the presentation the new 2026 research set out to explain mechanistically. Critical red flag exam pearl, dark tea-colored urine, CK greater than 10 times the upper limit of normal, and severe generalized weakness signal rhabdomyolysis, a medical emergency requiring immediate statin discontinuation, aggressive for fluids, and monitoring for acute kidney injury. In July 2026, a team at McMaster University published findings in Science Advances revealing something nobody expected. Statins don't just deplete cholesterol precursors. They quietly starve muscle cells of energy, and that starvation itself triggers an inflammatory alarm from inside the very cells the drug is meant to spare. Quick pause. If this breakdown is helping you, take a second to hit like and subscribe. It genuinely takes a lot of effort to make videos like this, and your support keeps them coming. Trace the new pathway step by step. Statins reduce isoprenoid availability, which lowers protein prenylation of small GT-pases in muscle cells. This impairs hexokinase activity and raises PDK4 expression, choking off glycolytic flux, the muscle cell's primary fuel-generating pathway. Reduced glycolysis then acts as a metabolic danger signal that muscle cells themselves detect. At the molecular core sits the NLRP3 inflammasome, a cytosolic multi-protein complex that senses cellular danger signals. Once activated, NLRP3 recruits and activates caspase 1, which cleaves pro-interleukin 1 beta into its active inflammatory form and can trigger pyroptosis, an inflammatory form of programmed cell death, via the pore-forming protein gastromin D. This is happening inside muscle cells themselves, not just infiltrating immune cells, redefining muscle fibers as active immune participants, not passive bystanders. It's worth being precise about the evidence level here. This was a preclinical study using isolated muscle cells and mouse models. Powerful for establishing mechanism, but not yet proof of what happens in human patients at clinical statin doses. That translational gap is exactly where the next phase of research needs to go. In the muscle cells studied, statin exposure reduced glycolytic flux substantially compared to untreated controls, while genetic or pharmacologic blockade of NLRP3 largely rescued the metabolic and inflammatory changes. Strong mechanistic evidence that this pathway, not cholesterol lowering itself, drives the muscle symptoms. Zooming out, This mechanism sits alongside other statin side effects clinicians already monitor: mild transaminase elevation, a small increase in new-onset diabetes risk, and rare cognitive complaints. Muscle symptoms, however, remain by far the most common reason patients and physicians reconsider therapy. 3 things make this discovery clinically important. First, it decouples the muscle toxicity pathway from the cholesterol-lowering pathway, meaning future statins could theoretically be designed to spare muscle prenylation. Second, it identifies NLRP3 and hexokinase as concrete drug targets. Third, it validates that patient-reported muscle pain has a real, measurable biological basis, not simply a nocebo effect. So what should you actually do at the bedside when a patient says a statin is hurting their muscles? The answer is not simply stop the drug. Cardiovascular risk reduction is too valuable to abandon without a structured approach. Clinical assessment starts with a focused exam. Test proximal muscle strength against resistance at the hips and shoulders. Ask about symptom timing relative to statin initiation or dose changes, and draw a baseline creatine kinase before deciding whether to hold or continue therapy. The SAMS Clinical Index, or SAMS-CI, formalizes this assessment using 3 domains: the muscle symptom pattern itself, the timing of onset and resolution with statin de-challenge and re-challenge response. Higher scores make a true statin-related cause more likely, helping clinicians avoid unnecessarily abandoning a life-saving therapy. Management follows a stepwise algorithm. First, confirm the diagnosis and rule out red flags like rhabdomyolysis. Next, try dose reduction or switching to a statin with lower muscle tissue penetration, such as rosuvastatin or pravastatin, which are more hydrophilic. If symptoms persist, alternate day dosing or a non-statin agent like ezetimibe or a PCSK9 inhibitor can maintain LDL control. The population-level stakes are real. Every patient who abandons statin therapy without an alternative loses a substantial fraction of their achievable cardiovascular risk reduction. Modeling studies suggest that improving statin adherence through structured muscle symptom management could meaningfully reduce preventable heart attacks and strokes at a population level. Weigh this honestly with your patients. Continuing a statin, even at a lower dose or with a switched agent, preserves a well-proven reduction in heart attack and stroke risk. Stopping entirely removes the muscle symptoms but restores the patient's original, often substantial, cardiovascular risk, a trade-off that deserves a shared decision, not a reflexive discontinuation. Let's lock in the essentials. Statins work by blocking HMG-CoA reductase. Muscle symptoms are graded from myalgia to rhabdomyolysis, and the newly discovered NLRP3-driven metabolic danger pathway finally gives that spectrum a molecular explanation. Keep the evidence hierarchy straight for exams. The cardiovascular benefit of statins rests on decades of large randomized controlled trials, the gold standard of evidence. The new NLRP3 mechanism, by contrast, currently rests on preclinical mouse and cell studies. Mechanistically compelling, but several rungs down the evidence ladder until human trials confirm it. Compare the old and new understanding side by side. The old view treated muscle pain as a vague, hard-to-verify side effect, sometimes dismissed as nocebo. The new view identifies a specific molecular cascade: reduced prenylation, impaired glycolysis, NLRP3 activation, with concrete, testable, and eventually treatable targets. Myth versus fact one more time. Myth: statin muscle pain is all in the patient's head. Fact: this 2026 research demonstrates a concrete, measurable metabolic-immune pathway inside muscle cells themselves. Real biology, not simply a nocebo response, even though nocebo effects can genuinely coexist with true pharmacologic myopathy in some patients. Last check before you go. According to the 2026 discovery, what is the proposed sequence linking statins to muscle inflammation? Here are the key references and sources for this video. Thanks so much for watching. If this helped, like the video and subscribe for more clear, simple explainers, and I'll see you in the next one.